Welcome to the Boston Structural Heart course. In this presentation, in the format of discussion and a panel, we will be discussing the various staffing models and reimbursement for imaging for structural heart disease. This is a very relevant and a very important topic, particularly in the context of the CMS ruling of 2021, which specifically laid down the roles of the cardiac surgeon, interventional cardiologist, and a heart team model that consists of an interventional echocardiographer, which could be a cardiologist or an anesthesiologist qualified in providing perioperative imaging. Now, this becomes even more important because there are certain specific guidelines regarding provision of anesthetic services simultaneously with imaging services. What are they and how they impact our reimbursement and staffing model now and likely in the future is a point which is very ambiguous, a little confusing, and somewhat contentious because it is still a moving target because a lot of advocacy by these professional organizations is still in works to perhaps revise and make it a little bit more sympathetic towards images, the reimbursement and the staffing model. So this is all that is on the table today, and I'll be discussing with various experts their opinion about this specific CMS ruling and its impact on our imaging in the future. Our first guest is going to be Dr. Michael Herring, who is the Vice Chairman of Clinical Affairs at the Beth Israel Deaconess Medical Center, has been one of the pioneers of use of perioperative transesophageal echocardiography in the operating room, and he has seen the evolution and the transition of transesophageal echo from a monitoring modality to a very vital procedural adjunct. I'll be asking him some questions, and the first question that I want to ask Mike is, what is the difference between a diagnostic and a monitoring TE, because that sets up the discussion for the rest of the panel.
Well, monitoring, there's a variety of levels to answer this, but monitoring and diagnostic TEE are governed by two different CPT codes. Monitoring is 93318 and diagnostics 93312. Monitoring is really, you're looking at continuously evaluating the pumping function of the heart, up to and including any therapeutic measures you may impart. Unfortunately, it is bundled with your anesthesia fee, so I can't tell you what you're going to get paid for it because it's not reimbursed, at least not at the federal level. Monitoring is not paid; it's bundled. The diagnostic can be billed separately from the anesthesia, and it's really used to see if a patient needs additional interventions, for example, to evaluate a new valve prosthesis or to manage unanticipated hemodynamic problems. So I think the average Medicare rate nationally is about $115 for the diagnostic fee. As I say, the monitoring is bundled. However, you can bill 93313 simply for pro placement, and the government will generously provide you with $29 for that service.
Okay. My next question to Dr. Herring was about this CPT code 93355 that relates to structural heart disease imaging and has generated a lot of controversy and confusion.
Yes, so 93355 is relatively new. It's, as you say, it's TEE for catheter-based cardiac interventions. We call it structural heart. It's Watchmans, TAVRs, TMVRs, MitraClips, and TriClips are the ones we do here at this institution most frequently.
Another question was, do we make more money by providing imaging for structural heart disease interventions as opposed to TE for cardiac surgery? That is, does 93355 generate more revenue than the CPT code 93312, which is for diagnostic purposes in open heart surgery?
It's significantly more, maybe even double, depending on where you are. So you're talking about going from, $115 to maybe $230 or something in that realm. So the delta there, is between $100 and $150, I would say.
Now that brings an important point, and that is that based on the reimbursement model that we make just about $100 more than a diagnostic TE for cardiac surgery. is it even possible to maintain an imaging service solely based on a reimbursement model for structural heart disease imaging?
I mean, you can do the math. Anybody can do the math. I mean, your cardiac anesthesiologists again are vary in reimbursement depending on geography, location, seniority. But at $100 a pop, you have to do an awful lot of structural heart studies as the imager only. Not you can't bill and give the anesthesia. Imager only to make that salary.
So based on this information that we can either provide the imaging services or the anesthetic services, which implies that a sole anesthesiologist cannot provide both the services. I asked the most confusing and the most controversial question that can I be the attending on record for anesthetic as well as the imaging for structural heart disease?
I think you won't be paid. I don't know that you're doing anything wrong. I think you would use your judgment as a consultant as to whether you can safely provide the anesthetic and care for the patient's hemodynamic perturbations as well as doing the imaging. But the CMS is not going to pay you if your name is on that chart. So if you try to finesse it by having a fellow that's also a fully trained anesthesiologist, if your name appears on that anesthetic record, you can't bill for the imaging.
So the next logical question is that, well, if I'm providing anesthesia and the imaging services at the same time, I may not bill for 93355. Can I still bill for 93312? That's the diagnostic code that we use for open cardiac surgery. It's better than being paid something rather than not being paid anything at all.
No, you can't. You can't downgrade your CPT code just to get some money from some payment for it. Yeah, I think that would probably be out of compliance, and I don't think your biller probably wouldn't let the bill go through by downcoding it.
So based on this current discussion, it appears that it is not a financially viable model to maintain an imaging team for structural heart disease interventions 7 days a week, 365 days a year, because it's only about another $100 for each case, and you need to do an awful lot of cases to make it financially viable. So under these circumstances, what would be the most optimal staffing and reimbursement model for institutions that are not doing that many structural heart disease cases to financially stabilize the situation and be able to provide these services to interventional cardiologists?
Correct. So it all depends on your level of institutional support. If your hospital is willing to increase their stipend to the department to provide a standalone imager that is not involved with the anesthetic, well, then you can make this at least a break-even proposition. If your institution does not support that, and you are compelled to do both the imaging and the anesthetic, you can't bill for it. It'll be a loss leader at that point.
So what Mike is referring to is institutional support for a staffing model for imaging services for structural heart disease interventions. My question is there any precedence of similar services being supported by institutions to maintain a service line?
They tend to support product lines that are profitable to the hospital, and the anesthesia bit is essential. They can't do it without anesthesia, and so they run it as a loss leader with anesthesia. They support anesthesia's losses so that they make a net gain for the hospital. It doesn't, and it's one of those things that you can really, the people that pay for their stuff, either it's coming out of your hide, the department's hide, or the hospital's hide. And so as you seek advocacy for payment, you can often, if your hospital's paying for this, say anything you can do to increase reimbursement for structural heart imaging helps us because it reduces our need for a stipend. So it can help you align with the hospital, at least for advocacy with CMS for payment.
Based on my personal experience, I can state that training and expertise in imaging for structural heart disease interventions is a challenging undertaking. But it appears that staffing and reimbursement is even more challenging. So I asked this question to Mike, who has seen the evolution of transesophageal echo from its very inception to where it stands today, that what are the options for cardiac anesthesiologists regarding structural heart disease interventions? First, and the easiest one is to give up and not be involved. or to increase advocacy at a professional level to get recognized as imagers and anesthesia providers like we do it in cardiac surgery? Or should we let the situation stay and ask for institutional support at a greater level so that we can be financially viable imaging service for the interventional cardiologist?
Let's take them one at a time. Should anesthesia be involved with structural heart imaging? Absolutely. That's a very easy answer. Yeah, I think that no one knew where it was going to go, whether this was a flash in the pan, whether anesthesiologists would be more broadly involved with imaging, and there was certainly no billing, for services for quite some time. So this is very similar. But we definitely need to be involved. We need to push the envelope as far as billing goes, and so that if you believe you deserve compensation for the work you're doing, you submit the bill. If it's rejected, you appeal it. There's an appellate process with all the payers and with CMS, and you push the envelope. The advocacy piece breaks down into a couple of buckets. One, the anesthesia organizations, anesthesia specific. So the SCA, for example, is an anesthesiology specific organization. They should be and are advocating for anesthesiologists getting paid for what they're doing. The ASA should also. But then there are organizations like the American Society of Echocardiography that have cardiologists, but they also have anesthesiologists as members. And that organization has the obligation to its paying membership to advocate for all of its members, not one specialty or the other. And similarly, the CPT codes we're talking about are really not provider specific. They're not subspecialty specific codes. They are applicable to any physician doing these techniques, these imaging techniques. And then the third part on advocacy, you have your anesthesia organizations, you have your organizations that have a mix of cardiologists and anesthesiologists. And then again, you have your hospital that's paying potentially a stipend, paying to support these services. They're very lucrative to the hospital. They should be advocating on your behalf with CMS or whomever else, saying that our anesthesiologists deserve to be paid for the services they are providing.
So now we'll invite our next panelist in this discussion, Dr. Peter Panzica from Westchester Medical Center in New York, who will be giving his opinion about these 93312, 93355, and Modifier 59 and its role in reimbursement for imaging for structural heart disease interventions. Let's get started. So welcome everyone, and welcome to Boston Structural Heart. As continuing with the billing and staffing model session for structural heart disease imaging for anesthesiologists to be specific, I have invited another expert on billing and staffing, my former colleague and currently the chairman at Westchester Medical Center, Dr. Peter Panzica, who has an extensive experience in dealing with these issues and trying to negotiate the maze of the CMS and insurance payments and everything. So we're going to be asking him the same questions that we asked Dr. Herring, but with a little twist. So welcome, Pete. How are you doing?
Good. Thanks for having me, Feroz.
Thank you very much.
Good to be here.
So Pete, we've already talked about it a bunch. So tell me first the difference between a diagnostic and a monitoring team.
I want to start out by, qualifying what I'm about to say. Is what I'm going to talk to you about is opinion and interpretation of Medicare requirements. If you really have any questions about this, you may want to consult with your billing company, your compliance officer, your local Medicare provider, or your commercial insurer, because the coding and rules regarding Medicare and reimbursement of intraoperative echo are ever-changing and complex. So today, we're going to talk about various CPT codes, which are procedural codes, ICD-10 codes, or diagnostic codes, and the modifiers. So, before we get into this, the CPT codes we're going to talk about, they basically tell the insurer what you did procedurally. The ICD-10 codes or diagnostic codes tell the insurers why you did what you did and do they meet medical necessity. Most of the intraoperative echo you will do, there will be a diagnostic code where you can indicate medical necessity, but not all of them, and those are changing as well. And then the other thing, I just want to go into other definitions with Medicare reimbursement for echocardiography is, there's different types of payments. So there's Part A payments, which reflect the facility fee. For echoes you're doing in a qualified facility like a hospital. And the other ones which most interest the physicians are Part B, which are the payment for professional services. Part A is often several times in magnitude of what Part B is. So just to give you a common example, and we're going to talk about these codes in a few minutes, the most common code, diagnostic code that you are going to bill is 93312, and the professional reimbursement for that may be just, say, in the ballpark of $110. But the facility fee is going to be somewhere in the order of $490. So location is also important. If you're doing, you're not going to be doing intraoperative echo in the office, but you're going to be, you could be doing, other types of echo in the office. And
May
so,
I ask one question, Pete? The
Sure.
facility fee is not reimbursed to the operator, that goes to the hospital.
It goes to the hospital, that is correct. However, if you're a physician and you're doing it in a non-facility, say your office, you will get somewhere in the middle of a total fee, say somewhere in the order of like $250, and that will cover both your professional fees as well as the costs of the practice costs of owning the business. So where you do this makes a difference. And then lastly, before I get into the question that Dr. Mahmood asked me about the differences of these codes, is also the thing I mentioned that's called modifiers. So modifying codes tell the insurer additional information. And the most important code for an anesthesiologist, the most important modifier for an anesthesiologist is the 59 modifier. And the 59 modifier specifically unbundles the echo services, which are, from the anesthesia services. So years back, the ASA fought to say that this is not bundled when we're doing a diagnostic study, and that it should be treated separately. It requires a level of training and expertise to provide the diagnostic services that are different from these anesthesia services you're providing. So you will get paid for both, but your billing company has to use the 59 modifier, which.
So technically, when we're doing, let's say, intraoperative TE for mitral valve repair, or any monitoring diagnostic TE, our billers, add the 59 modifier so that it unbundles both services, and we bill for them separately.
We will specifically get into that when we talk about CPT code 93355, the structural heart code, and we'll talk about it specifically for mitral valve repair. But regardless, when you're using that code, and we'll go into this, the 59 modifier does not apply. It cannot be unbundled.
So if I understand it correctly, what you're saying is that for intraoperative TE, we can unbundle the anesthetic and the imaging services by applying this code, and the CMS has agreed that you can provide anesthesia and you can provide echo services at the same time. The same provider can do that.
Exactly, with the exception of the code that is specifically for structural heart guidance, which is 93355.
So once we apply 93355, we cannot apply modifier 59.
That is correct.
Okay, so my next question, now that we've gotten into this one, Pete. Now this is like, I asked this question to other people also. And specifically the CMS statement says that the practitioner providing the imaging services may not be the person involved in anesthetic services. So some people interpret it to the maximum to their advantage, saying it says you may not, which means you possibly can, but in that situation, you should apply 93312 and just use the diagnostic study thing that we can use for intraoperative imaging. Is that true? Or is that
So,
being under billing your services?
so that question is very nuanced because it's not so much a billing thing, it's a Medicare participation for mitral valve end-to-end repairs. And if you'll allow me, let me explain, let me go through the standard diagnostic codes for which the 59 modifier applies. And those are, and you asked the question as far as diagnostic versus monitoring. So if you'll allow me to go through those first, it may then make it easier to understand the newer code, the 93355, and how that is related to what you need to do to get paid for that one. So if you allow me to start with the more basic codes. So the CPT codes for intraop TE range from 93312 to 93325. The first one, 93312, that's kind of the workhorse of most of the intraoperative TE that you will do for cardiac surgery. And this is different from the monitoring code, which is 93318, which you put in a probe and you're basically following a patient hemodynamically. So let me start with 93312 and its requirements. So 93312 requires probe placement, it requires image acquisition, image interpretation, and report. And like I said earlier, the professional payment will be in the ballpark of about $110 for that. The key thing with that and how that differs from 93318 is you need to write a report. You need to do all those things and write a full diagnostic report of your findings in the medical record so that it is retrievable, and that diagnostic report also needs to go to the billing company so they saw that you did that. Now, when you're doing 93312, there's also add-ons that you typically put with that. So the first and very common add-on is for pulse wave and continuous wave Doppler, or 93320. That will get you a professional fee of somewhere on the order of $18 more, but you do it, you might as well get paid. The next one's color Doppler, and that's 93325. That will get you, ready for this, about $3 for your professional fees. But you do it, document it, you get paid for it. And also, there are fees for 3D rendering. So 93319 is if you're doing 3D with post-processing as part of your study, you put that in as well, and that'll get you about another $25. So that's your workhorse, 93312. Those are the add-ons for professional fees, which you do in most of your studies. Now, the monitoring one is 93318. 93318 is, it does not require a report. And the problem with it is that too, Medicare will not allow you to use the 59 modifier. So you're essentially not getting paid for it unless somebody else is doing a monitoring study and billing for it under their name. It is bundled into the anesthetic care. It does not require a report, and it too will make you about $110. But if you're the person doing the anesthetic, you will not be able to get that money. Now, the hospital may still be able to get the facility fee for use of the echo equipment if it's billed properly. And I can't speak for private insurers. I don't know what the stance of all the different private insurers are if you submit a diagnostic study. But for the most part, Medicare will not pay for that. So I mentioned the codes 93312 for diagnostic, and I jumped to 93318 for monitoring. Now there's a bunch of codes in between that, 93313 and 93314. What 93313 and 93314 are, is they basically break down 93312 in different components.
Okay, so you cannot use those codes unless you use 93312.
No, so 93313 and 93314 need to be used together, but 93312 is just for probe placement. So sometimes the anesthesiologist will place the probe, and somebody else, the cardiologist, will do the diagnostic part, and that person doing the rest of it, not probe placement, but the rest of the diagnostic study, recording and generating a report, will bill under 93314. So the anesthesiologist who's inserting the probe and just billing for 93313 will get about $11 for that. The cardiologist or whoever doing the second part of that, the report, all that work, will get about $90 for that. But that's to basically codify situations where those things are done by two different people. So those, 93312 is what most intraoperative anesthesiologists are doing. 59 modifier to unbundle to anesthetic care, but there are instances where 93313 and 93314 are applicable. So those are those three codes. Then the next three codes, 93315, 16, and 17, are related to congenital cardiac disease. So if you're doing a study in a patient that has a congenital lesion, bicuspid aortic valve, ASD, something else that is deemed congenital, that study pays a little bit more, and you should code it as 93315. And the delta for that is probably going to be an additional $20, but if it's available, you might as well get it. So 93315 basically is the same as 93312, but in patients for congenital lesions. And then after that, 93316 and 93317 are the exact same as 93313 and 93314, but probe placement and report.
Doppler and continuous and pulsed-wave Doppler usually.
Well, those are the extra two that you will add on, 93320, 93319, when you do those, as you do in most exams. But specifically 93315 through 93317 are related to congenital exams. Which
so in this context, Pete, let's just say if I'm doing a structural heart disease imaging study and someone else is doing the anesthetic, and if I do a structural heart disease study, we apply the 93355 code. How much is the difference between 93312, an ideal study built and everything coded, and a 93355 study?
In short, your answer is about $120.
So the next question is, do you think that based on the reimbursement model of imaging for structural heart disease that you make another $150 for maybe $110, $120 for this structural heart disease imaging, is there any program that can support a fiscally viable program purely based on reimbursement for structural heart disease imaging?
I mean, it really depends on the program and what the setup is and who's available to do what. So before I answer that question, let me just delve a little deeper into what 9335 is. Obviously, it's more reimbursement. This code came out on the heels of structural heart procedures years ago, and what the physicians, presumably the cardiologists, wanted to show was the level of increased work associated with these guidance echoes, meaning they need to be there for the procedure. If they were doing, let's say they were coming into the OR, they can come pre-bypass, do a study, come post-bypass, they can do whatever they need in between, but guiding a procedure requires somebody to be there at all times. So the people who worked to create this code wanted that extra work reflected. Now, the problem is that when this code came out, Medicare basically said, okay, we will pay you extra, but it cannot be unbundled to anesthetic care. It has to be someone separate. And the ASA and SCA tried, the economics committee tried very diligently to say the anesthesiologist is there doing the procedure. It's more work than 93312. They too should get the extra money. But despite that, they have so far not been able to unbundle that despite
So,
several
Pete,
attempts.
may I interject over here? This is with permission from Chris Troyanos. I had a conversation with him a week ago or so, where he said this is yet unpublished data where they had a survey of the Medicare billing for all structural heart disease, and they found that 50% of the cases people not billing for anything,
Right. I actually spoke to Chris too.
and 50% are doing 93312.
Right. So no, what he said was that about 40% of the mitral clips are either not submitting an echo report at all, or they're billing 93312. The other 60% are billing 93355 and must be meeting the criteria of having a different anesthesiologist, interventional echocardiographer, whether it's an anesthesiologist or
A
a
cardiologist.
cardiologist providing that, and they're billing it properly and meeting the guidelines. So the thing is, you need to separate out mitral clip imaging from other structural heart imaging when it comes to what it means to use this code. And the reason for that is because it's not so much a billing issue, having a separate imager that's not doing the anesthesiologist to do the imaging. It's more of a condition of participation in the program. Now, this came out in 2021, where Medicare said that interventional echocardiographer may not provide anesthesia. And this is conditions for participation in the program, not billing. So these people who are submitting 93312, they're probably getting paid on it, but they're audited. They run the risk of them saying, well, you obviously did an echo for this. So the people who are not billing, you obviously did an echo. So you're not meeting the conditions of participation, or you're submitting a code that shows that the anesthesiologist is doing the echo and providing the anesthesia care. So again, this specific issue with regards to mitral clip is more about participation and meeting the requirements within that program. So let's take it for other procedures like Watchman and paravalvular leak repairs. Again, if you submit 93355 and have another person doing it, you're going to get that extra $120. But if you don't have the ability to do that, the next question is, can that anesthesiologist, and now we're not talking about participation in a mitral clip program that Medicare requires, we're just talking about billing. Can the anesthesiologist bill 93312 and at least get something for that study, the $110 like I mentioned?
It's not a mitral clip study. It's a PFO closure or something like that.
Yeah, it's non-mitral clip, because that's the one which has those conditions for participation, which says an interventional cardiologist or anesthesiologist cannot be furnished the anesthesia for that procedure. So something else. So can the anesthesiologist put in a bill for 93312 in those other cases? And the answer is controversial, because the most appropriate code is 93355. You're guiding a procedure. So not putting in 93312 is something known as undercoding. And you're not supposed to undercode. You're not supposed to submit a lesser code. But do people do it? Yes. As demonstrated by what Dr. Troiano said, even with the mitral clips, that there's a group of people who are still putting in 93312, probably getting paid for it, but potentially risking the conditions of participation if they're audited. And the thing is, you basically can submit anything as far as billing, but it really comes down to, will it withstand the scrutiny of an audit? And that's always where you're taking some risk. So, I hope I made that clear as to what those differences are.
The point I'm trying to get to is, this is an evolving field in its kind of infancy. And you yourself have been at the start of transesophageal echo when it was anticipated to be a turf battle between cardiologists and anesthesiologists in doing this thing. and how it shaped out that it was inherited by anesthesiologists. Agreed that these coding and billing issues were not that important at that time. Where do you foresee this thing going in the future?
So as far as this MitraClip issue, and as far as 9335 in general, the ASA Economic Committee, they've not given up their fight. They will continue to push the fact that the anesthesiologist should be able to provide both and get this unbundled like they did with 93312. They've tried several times. There's changes in CMS leadership, and they will continue to try. But it really comes down to how a program is able to cover these cases and what the evolution of a structural heart program within a hospital is. Where when I was, with you in Boston, it was there from the onset, and it quickly showed that being attached to the operating room was not worth a cardiologist's time or reimbursement. To pay to be in the OR that much time, and as anesthesiologists picked up that expertise, they were able to provide that level of service and soon thereafter get paid for it. But that's not the way it is in every hospital, particularly with structural heart. Structural heart definitely takes on a degree of difficulty, and some programs have the ability to train anesthesiologists to do this well, because it's a lot of 3D, and some programs don't. And some programs, the cardiologist, will be more willing to come and guide these procedures. So it really is a mixed bag, and what you do with this really depends on your ability to staff it, your expertise, more so than the money. But if you can maximize your billing and be in compliance, then you should be able to do it. If you can easily have a second person come and do that study, whether it's a cardiologist who may be busy reading transthoracics in the echo lab, or another anesthesiologist has the ability to come in and be there and still you provide the service, but also be in compliance with whatever else they're coming, then you can attempt to maximize your billing that way. But in the end, it isn't so much the money, but your ability to furnish the service.
But looking at it, predictions are hard, particularly about the future. But where do you see this thing going? Purely, let's leave the economics alone. And do you think it is even worth it for programs to push to get involved in this thing, or just leave the turf alone for whosoever eventually comes out on top?
So what do you mean by programs pushing to what?
For example, in our program, and you were there when we started it, and we made an extra effort to be able to staff these. And honestly, not that you're here, it's thanks to you and your flexibility in staffing and allowing me to be in the structural heart disease rooms for an extended period of time. Now we have a program 10 years later. And we are doing almost, at least 5 to 10 MitraClips a week, And so this is thanks to that vision at that time, which seemed like a lost option in the short term, but strategically paid off to be a big thing for the program. Do you think people should make, these strategic decisions rather than and sustain these tactical losses?
So I certainly think it extends the value of an anesthesiologist by having these skills, by being the person to be there, provide the anesthesia care at a very high level, but also be there to image and not have to call somebody else or really worry about that. And again, cardiologists who are trying to do billable work, their best efforts are probably in an echo lab where there's tons of studies to read one after the other, where their professional fees are done to, with that. So I think similar what happened in with the birth of echo and anesthesiologists doing it in the operating room. The same principles apply, that it may be difficult for a cardiologist to break away and spend significant time in an operating room, but every program is different. And the anesthesiologist being able to invest and train, having the desire to do that, having the staffing to do that. I think it varies from program to program. So each program is going to evolve around its own constraints. So I think it's great what was done in where we're in Boston and at your program, and putting that investment in and giving people the time to learn it and develop the expertise. But it was a lot of work, and all programs out there don't necessarily have those resources or the skill sets or the desires to take that on, but
Or the vision.
or the vision. Uh, but regardless, I think as with any program, in the operating room, we've established our intimate relation with the cardiac surgeons. We often do teas in the ICUs because of that. But it really is, again, keeping those relationships with not just the surgeon or the cardiologist proceduralist doing the structural heart cases, but the imaging cardiology echocardiographers as well. So having those relationships so you can work together, cross cover each other. So people go on vacation, so anytime you can develop a higher level of expertise as an anesthesiologist, you certainly increase your value. So it is highly, highly encouraged that programs be able to do this. But the work involved, how slow it is to do that. And it takes not just a vision, but a lot of passion and energy to be able to see that to fruition. So it's a lot of work, and every program is different.
Well, Pete, thank you very much. It's just about time, and honestly, it's way more than I was anticipating. The level of knowledge and depth of information that you provided was honestly mind-boggling. And this would be go great, hopefully, with the audience. People understand. And in short, we're going to have another session with you and Chris Trianos and a couple other guys at the same time, so to have a little bit more fruitful discussion. Well, thank you very much, Pete, and good luck.
Thank you.
Well, that brings us to the conclusion of this very important session. And from the preceding discussion, at least this thing become obvious that this is a very complicated topic. It's a moving target. The final word is not out there yet. And there are various staffing and reimbursement models which cannot be universally applied across medical centers and across various regions and across various insurance reimbursement companies. So therefore, we hope and plan to continue this discussion and involve more experts in this discussion and bring to you the latest rulings of the national organization as well as the advocacy efforts in the line of the CMS ruling of having an anesthesiologist not being involved in the imaging if they want to be reimbursed for both the services. Thank you and good luck.